Good morning, dignitaries on and off the dais, colleagues. We are here to do a case presentation on surgery. Myself, Kannagi, this is Jagajabas. We'll move on to the presentation. A 52-year-old female, Mrs. Regitri, who's a housewife by occupation, hailing from Trivandrum, belonging to lower social middle class, according to modified Kupaswamy scale, came to the OPD with chief complaints of pain in abdomen for the past 4 months, vomiting on and off for past 1 month, and yellowish discoloration of eyes and urine for the past 1 month. History of presenting illness. Patient was normal 4 months back, by which she developed pain in abdomen, which was insidious in onset, dull aching type of pain, not radiating, aggravated on taking food, and is continuous in nature. Patient also complains of vomiting on and off, which is spontaneous in nature, non-projectile, non-bilious, aggravated on taking food. The vomitus contains saliva, minimal food and scanty in amount. It is not associated with hematemesis. She also complains of yellowish discoloration of eyes and urine for the past 1 month, which is insidious in onset and is progressive. History of itching present over the arms and abdomen. History of passing high colored urine. History of passing clay colored stools. And there is significant history of loss of weight and appetite. No history of fever with chills and rigor, blood transfusion, use of any hepatotoxic drugs, mass per abdomen, altered sensorium, and nyctalopia. Past history, she is not a known case of diabetes, tuberculosis, or hypertension. No history of previous surgeries or blood transfusion done in the past. Family history, no history of similar complaints in the family. Treatment history, patient did not take any medications for the complaints. Menstrual history, menarche at 13 years, 28 days, it was a regular cycle and she attained menopause at 50 years. Personal history, she consumes mixed diet, loss of appetite and altered bowel habits present, disturbed sleep. She is not an alcoholic, no history of smoking, drug allergy or substance abuse. General examination, patient was alert and cooperative. She was moderately built and moderately nourished. Weight is 51 kg, height 155 cm, BMI 21.2. Patient is icteric, scratch marks present over the abdomen and elbow. Signs of liver cell failure is absent, no lymphadenopathy and edema. This is the patient picture showing jaundice. Vital, she is afebrile, pulse rate 68 beats per minute, regular rhythm volume, normal in character, no radiofemoral delay. Respiratory rate 18 per minute, BP 124/88 mmHg. Examination of abdomen. After getting consent from the patient, she was examined from nipple to the mid-thigh in a well-lit room along with the female attender. In inspection, we found that the abdomen is scaphoid and all quadrants move equally with respiration. Umbilicus in midline, no abdomen distension, no scar, sinus and dilated veins, no visible peristalsis, hernial orifices free. This is presence of scratch marks over the elbow. Palpation, superficial palpation, abdomen is soft, no warmth, mild tenderness over the epigastrum is present. Gallbladder, a mass palpable in right hypochondrium. All borders except the upper border felt. It's globular, smooth surface which is firm in consistency, moves with respiration, horizontal mobility is present.
The history suggestion of jaundice?
Yes, sir.
So jaundice is a status of the patient which is diagnosed to almost a full extent clarity of 85 to 90% out of the history, a well taken history.
Yes, sir.
So what are the points positively leading to a type of jaundice from your history?
Sir, she has yellowish discoloration of eyes and urine, sir. So it should be probably...
You very rightly noted there is a deep discoloration of the urine with clay color history of cancer. How will you tally that from the history?
Sir, patient complained of yellowish discoloration of urine, and when we asked the history of stool, she mentioned that the stool color has been changed.
I got it, but then from the history of dark colored urine and clay colored stool, what are there in your point to arrive at the cause of jaundice?
I think it's a case of obstructive jaundice. The level of conjugated bilirubin is raised, sir. That is why it is water soluble and the patient is excreting conjugated bilirubin, and so that's why the patient has high colored urine.
In obstructive jaundice,
Yes,
what
sir.
is influxing, conjugated or unconjugated?
Conjugated bilirubin, sir.
What is the reason?
Sir, conjugation, the level of obstruction is extra hepatic, sir, outside the liver. So conjugation
So
is
there is nothing wrong in the initial phase.
Yes, sir.
As far as the hepatocytic function
is
of,
normal.
of uptake,
Uh,
then
conjugation and
conjugation
excretion.
and excretion. Especially in case of extra hepatic type of. Now, regarding the pain, what is your inference from the pain? What are you going to sort it out? Where is the pain initially felt?
So she felt it over the epigastrium, sir.
Ah.
Uh,
in types of obstructive jaundice, you expect a pain usually in the epigastrium or somewhere else? Or is there any history of pain? There need or need not be pain history at all as far as obstructive
So
jaundice is.
pain may or may not be present, sir, but this patient has dull aching type of pain.
And pain when present, what is the sorting
It
out
may
of
be
pain?
due to obstruction, sir. Obstruction of the duodenum
I
due to
agree-
any growth.
I agree. If it is due to an obstruction distal down, you get something like a biliary colic, something like a biliary colic. But in case of malignant obstructive jaundice, what is the sort of history of pain? Will there
It's
be
initially
pain
painless, sir.
initially.
Later on, the patient will start getting pain.
So how do you get that description of malignant cause of jaundice being described in terms of pain? Initially, there may not be any pain. So what do you call it? Painless.
Painless progressive jaundice, sir.
When do you get pain?
During the later stages, due to retroperitoneal infiltration or pancreatic duct obstruction, the patient, or duodenal obstruction.
What is the cause of later phase of pain in case of carcinoma head of pancreas?
Due to compression of tumor on the spine or around the plexus.
Is it to the spine or something specifically because pain anywhere else, pain is caused by irritation of the nerve endings, isn't it? So it should be something sensory irritation, isn't it? What are the nerves being involved?
Perineural.
Can you name it? Retroperitoneal, sensory nerve endings. What are the nerve endings? Is it somatic
So
or is it
splanchnic
autonomous?
nerve.
Is it autonomous? Splanchnic sensory nerve endings. I agree,
splanchnic.
isn't it? What are the nerves coming there?
Celiac plexus.
Not celiac plexus. It gives contribution to celiac plexus later. But the nerves irritated by the head of pancreas is splanchnic nerves. Greater splanchnic, and where are they emerging? From which root? You have the hiatus in the diaphragm, major hiatus and minor hiatus. This one among the constituents, one on either side of the major, in addition to the major hiatus, greater and splanchnic, small micro hiatus.
Okay, sir.
What is the acholoric jaundice? Heard of the
Sir,
term?
acholoric jaundice, it is seen in hereditary spirocytosis, sir. The patient will not have high colored urine. I mean, the bilirubin is not excreted through the urine, sir. It is the unconjugated bilirubin which is raised in the patient.
Why it is not excreted? Acholoric jaundice. Why it is not? Because it is
Because it's not water soluble, sir.
It is not soluble. It is not soluble. Water soluble.
What type of vomiting in this patient?
Ma'am, non-bilious vomiting, ma'am, as I've mentioned there.
Usually vomiting is there, but non-bilious vomiting means
Ma'am, bile is not the content, ma'am. The patient,
okay. What are the other conditions that can lead to non-bilious vomiting? If there is any obstruction,
atresia, no.
common.
Gastric outlet obstruction, ma'am.
What are the causes for gastric outlet obstruction?
Ma'am, chronic duodenal ulcer with cicatrization or carcinoma stomach.
Carcinoma pylorus rand. Okay.
When do you expect this hematemesis? What condition?
Hematemesis can be seen in periambulary or carcinoma stomach can be associated with hematemesis, sir.
Any other conditions?
Jaundice patient with hematemesis.
Jaundice patient with hematemesis.
Periambulary carcinoma due to sloughing.
Yes, that is one thing.
Advanced stage. bleeding in obstructive jaundice? Maybe due to
Fluke,
Liver fluke, you mean?
liver fluke, yeah.
No, but
coagulation of not.
no.
Coagulation.
Ma'am was pointing you to a scenario of having hematemesis as a manifestation of obstructive jaundice. Can the liver be damaged or diseased before getting this obstructive jaundice?
Yeah, due to obstructive jaundice, the liver may become. Due
Suppose
to
if it's a de novo obstructive jaundice, you may not get hematemesis. But a liver can be, underlying liver can be disease. What is the disease which can cause obstructive, hematemesis? What's the commonest liver disease which can lead as a presentation with hematemesis?
cirrhosis.
What is the liver disease?
Liver disease, hematemesis.
Whenever you hear liver disease, hematemesis, what should be the one which is coming first to your mind?
Portal hypertension.
Portal hypertension. So a patient might have had a portal hypertension, cirrhosis underlying as the basic pathology, then you are getting obstructive jaundice, irrespective of the cause. Probably you get.
What is the cause of itching?
Ma'am, itching is due to deposition of bile salts, which induce histamine and that irritates the nerve endings.
As a treatment?
Ma'am, resin, cholestyramine resin can be given to the patient.
So in this case, the pulse is 68 per minute.
Yes, ma'am.
So what the pulse in obstructive jaundice?
Ma'am, bile salt can get deposited in the pacemaker cells of SA node and thus conduction can be delayed. So we expect relative bradycardia in patients with
Okay.
jaundice.
And one more question is regarding the depth of jaundice. Is there any undulation or fluctuation in the depth of jaundice? Was she ever free from the jaundice at all? Was there any history of jaundice free and jaundice full?
No, sir. This patient was progressively
What do you technically call DAS?
waxing and waning of jaundice, sir, or intermittent jaundice.
What is the difference between intermittent jaundice and waxing and waning?
So waxing and waning, the jaundice levels doesn't reach the baseline, sir. It because of sloughing of tumor, it will be relieved, but will not reach the baseline. But in intermittent jaundice, the patient will be completely relieved, and then they'll get another episode of
Tell
jaundice.
me one example each for this.
So
that it will
intermittent jaundice can be due to stones, sir.
Ah.
Once the stone relieve, the jaundice will also relieve, and the patient again gets jaundice. Intermittent jaundice in periambulary carcinoma, sir, due to sloughing of tumor.
No, you are telling intermittent jaundice can be due to gallstone. It may be passed to the duodenum and then patient will be totally relieved. That I agree.
Okay,
But for the periambulary, is it routinely intermittent or is it
Waxing and waning, sir.
It's waxing. Can you get in periambulary and intermittent jaundice at times at least one frequency at least?
Yes, sir.
It's possible, is it? Because the entire distal lumen may be rebored or open. That's my question. Whereas in head of pancreas,
No,
there
sir.
is no fluctuation at all, or no difference in the level of it. It will be only painless progress. That's the most thing. And about the itching, you said they involving the entire body or peripheries? Limbs?
Sir, it's around the abdomen and the arms, sir.
Okay. In periambulary, do you always suspect a clay-colored stool or some other?
Silvery stools can be
Silver.
present, sir.
These are all the points to be stressed, especially for the undergraduates. And chills and rigor, if you get fever, etc., which is, what does it imply?
Cholangitis.
Cholangitis.
Cholangitis. Can you get cholangitis in obstructive malignant jaundice?
Yes, sir.
What's your idea about cholestatic jaundice?
Cholestatic is due to stasis of bile. The patient might
What is it commonly due to? What are the common causes of cholestatic jaundice?
stasis.
Because I am sorting it out because jaundice to up to a percentage of 90% is diagnosed out of a well taken history. That's it. As undergraduates, you should probe into that, not PG alone, isn't it? So, what are the drugs?
So drugs, hepatotoxic drugs, isoniazid.
No, there is a lot of difference between cholestatic
Cholestasis.
cholestasis inducing drugs and hepatotoxic. What do you mean by hepatotoxic drug? That is different.
Sir.
Paracetamol is a hepatotoxic.
Hepatotoxic drug.
It specifically induces hepatocytic function dampering or necrosis. Isn't it?
Yes, sir.
Whereas cholestatic need not. Hepatocytes may be,
OCPs can produce OCPs.
OCPs, I agree. Anything else? In CNS, what is the drug which is commonly used, can cause? should ask for any history of psychotropic
Seizure.
drugs being used, like chlorpromazine
Chlorpromazine.
related analogs or antidepressant. They can temporarily cause colitis. Rifampicin,
They are hepatotoxic,
it
sir.
is it can be both. It can be hepatotoxic as well as cholestatic.
Okay, sir.
So these are all the drugs which you should probe in. Any other thing in the history you have to ask? History of operations, did you ask? before?
I have asked, sir. I've mentioned it, sir.
What is the relationship of history of previous operations?
Cholecystectomy.
Post-operative.
Post-stricture formation
Yes,
can be
there is a
mentioned.
point in your statement. If a patient had a cholecystectomy, probably you may think of stricture
Stricture, sir.
lesions. Other than that, patient is subjected to general anesthesia. How do you correlate? If a patient comes with jaundice following post-op phase or within a month of post-op, etc. Any other thing?
Sir, post-op, the patient comes with jaundice.
Other than surgical causes, anything else?
Blood transfusion, sir.
Transfusion jaundice can be there. In olden time, chloroform when being used, noxious gases can cause hepatocytic. What's the commonest blamed drug causing hepatitis? Acute fulminant hepatitis, if a dose is exceeded.
Paracetamol.
That is, so to say,
Acetam-
notoriously known as the suicidal drug, isn't it? Because if you exceed the limit. So, frankly, hepatocytic is it. Any other aflatoxin which you should mention? History of some food intake.
Heavy meals.
Poisoning history.
Heavy meals.
Poisoning, yeah, I agree. Poisoning. Which poisoning? There was a beautiful article in Digest some years back, about some tourists visiting African seashore subjected to liver necrosis. Can you now just spoil it? I'm giving a clue. Sorry. Can you circulate a mic there to the students so that they can...
Methanol. they do.
Methanol.
Ethanol.
Methanol.
Methanol. No, I'm asking about food substitutes. Aflatoxin.
Aflatoxin.
Two of them are succumbing to death because of acute liver.
Mushroom.
Mushroom. Great answer. Great answer. Mushroom poison is that issue not happen. Okay. Because if we take the history, it may go for hours, but I think we have time limit. Something more from my colleagues. Yes. Okay. Yes.
So we'll go on to examination.
Yeah, please,
sir.
please proceed.
So,
We
sir,
can't cover the entire jaundice history questions alone in half an hour, but I think we have sampled some queries from the student side. I am always welcoming it if you want to clarify anything related to the history of a jaundice patient.
So patient was alert and cooperative, moderately built, moderately nourished, weight 51, height 155, BMI 21.2. Patient is icteric, scratch marks present over abdomen and elbow. Signs of liver cell failure is absent, no lymphadenopathy and edema. Vitals, afebrile, pulse 68 beats per minute, respiratory rate 18, BP 124/88.
Can you just quickly say what are the signs of liver cell failure you look for? Medicine people teach you a lot than we people, but still.
Yes, sir, from head to
Alopecia.
toe it's alopecia.
Just enumerate only.
Sir, alopecia,
Medarosis.
palmar
Spider
erythema,
neve,
spider neve,
Duke-
bilateral parotid enlargement, caput medusae, pedal edema.
Okay, very good.
Female patients.
No cross discussions because it may spoil the beauty of presentation. The presenter is necessary. You can ask, you can stand up and ask any doubt individually. Yes.
Examination of abdomen. After getting consent from the patient, she was examined from nipple to the mid-thigh in a well-lit room along with a female attendant. On inspection, abdomen is scaphoid. All quadrants move equally with respiration. Umbilicus in midline. No abdominal distension. No scar, sinus, dilated veins. No visible peristalsis. Hernial orifices are free.
What do you mean by umbilicus in midline? Can the umbilicus be away from the midline?
Yes, sir. It can be shifted up or down.
That's what you mean, isn't it?
Or it can be.
You know, it's still in the midline. Still in the midline, isn't it? So it may be distorted, or it may be obliterated more, or dimpled more, or it may be protruded. These are, or it may be distorted, cephalic or caudal, isn't it? I won't say upward and downward because it depends upon the position of the patient. That's why I said cephalic means towards the head or down to the pelvis.
Palpation, superficial palpation, abdomen is soft, no warmth, mild tenderness over the epigastrum is present, gallbladder, a mass palpable in the right hypochondrium, all borders except upper border felt, globular mass, smooth surface, firm in consistency, moves with respiration, horizontal mobility is present. Deep palpation, liver, spleen and kidney not palpable, hernial orifices are free.
Now you are just writing down only the positive findings which you got, isn't it? As far as
Yes, sir.
inspection. Say gallbladder swelling.
Sir.
Usually, gallbladder swelling is better made out of inspection
It's
or
inspection, so better seen than felt.
What's the reason? Why it is not easily palpable?
Because the upper border is confined to the, upper border is not palpable, sir.
That's a usual misconception about the palpability of upper border. Why not? If upper border is not palpable, you can get the lower border or the lateral or medial border, etc. That's not the reason. Upper border need not be palpated. Gallbladder, you may not be able to palpate the upper border at all sometimes, most of the cases. Unless it is a pedicled gallbladder itself.
It's present in the fossa, sir, so.
No, it is a very soft, bogies wall, thin wall usually, not filled in tense status has to be better palpable. If it is a tense gallbladder, mostly it is in favor of palpatory finding also. But if not tense, if moderately distended, being a very thin wall, it's yielding to finger, and that may disappear as palpatory mass. That is the reason. It's because of its tendency to yield to the finger, not as a border or a surface to be felt. But better seen when it is having breathing. That is the reason. Upper border may be palpable, may not be. Usually may not be palpable. That is true.
Okay, sir.
What are the other things you have to look for in inspection and palpation in abdomen? Apart from your presentation, any other thing you have to look for?
Point to this case, these are the findings.
Left supraclavicular fossa.
Or left supraclavicular fossa.
And
That
the
I've
right.
mentioned, ma'am. Yes, ma'am. I've mentioned, yes, sir. Yes.
No lymphadenopathy.
Nobody in edema.
Inspection in
And
inspection.
last, after auscultation, I put examination of lymph node. Okay, sir.
Without left supraclavicular fossa, examination of the abdomen is
Not
incomplete.
complete.
If it is a metastatic carcinoma, you will be getting enlargement of the left supraclavicular node.
What is that node called?
Virtuous node, sir.
Virtuous node. It is written as cho, but pronounced better as show, being French.
Shaw's node, sir.
Virtuous. What is that belonging to in cervical lymph node? Which group of lymph node that is? Why I ask that question is with a purpose, with a genuine purpose of recent evolution. That's it.
So level or
Cervical lymph nodes are classed into from 1 to 7. Isn't it? To which level you will ask? Attribute this Virchow's lymph node. You know that. If you are not knowing because it is not pertaining to abdomen, I can leave that question. But only thing which I want to highlight is this was included under medial supraclavicular lymph node, and medial supraclavicular lymph node was included as under level 5 till recently, because now it is included under level 4, lowermost of the vertical anterior group. So that's a concept change that has to be stressed. That is for the undergraduate, that is enough. It's enough for the time. Yes.
Name of the sign?
Tracheus.
How the meds goes there?
Lymphatic.
so through thoracic duct.
Yes.
Uh,
Thoracic duct drains into?
Subclavian vein.
subclavian vein and
Yes. From,
So-
subclavian vein, junction between the
Two heads of
No,
Sternocleidomastoid.
junction between how many veins there? You said subclavian, but there is a fusion of subclavian vein with which other vein?
IGV, internal jugular.
Then jugular and subclavian junction, and the reflux of the thoracic duct after draining that is to the lymph node of that area. That is the reason why you are getting that. But his question is, the spread is actually, though it is not related to blood, this spread is lymphatic spread. That's what you mean to stress. Yes.
Examination of other system, respiratory system, air entry equal and adequate on both sides. CVS S1 S2 hurt, no murmurs. CNS no focal neurological deficit. Per rectal examination to be done.
I may be wrong. Did you comment about the genitalia and the groin? In the
Sir,
abdominal
genitalia and groin appears to be
much
normal.
has
Sir.
been said about the supraclavicular fossa, but on inspection itself you should have commented upon the genitalia and the groin, isn't it? For any abdominal exam.
Yes, sir.
Anything else you must miss? If I am not wrong, did you include the per rectal examination?
Per rectal examination.
It is written. Or include that. Include. I have no objection.
Include
Okay,
it,
okay.
sir.
In CNS, what do you expect?
Sir, CNS hepatic encephalopathy the patient might have, sir.
You'll have? What is that?
Tremors, flapping tremors.
How do you elicit that?
Sir, ask the patient to
Outstretch
sit
the
and outstretch the hand, and we'll check if the patient is able to hold it in position or if it.
You just give a
That's like the old thing, sir. Now they told that just.
very good. Okay. Okay.
Can you
proceed.
demonstrate how is the flap?
Sir.
You outstretch it and then it falls. The eagle is flying, there is some flap, or the dove is flying. So, what is this hepatic encephalopathy due to? What is the reason in liver failure?
Sir, CNS is involved.
Why CNS is involved? What is the reason?
The bile salts get. It stimulates the nerves in the.
Bile salts will directly go and stimulate the nerve. I will just help you. It is due to accumulation of certain substance.
Ammonia.
Ammoniacal products are the one which is going and causing alteration of the bendation. That issue. And that's the very purpose of we giving bowel wash and other things, prebiotics, etc. in case of a jaundice to prevent the hepatic encephalopathy.
Summary: a 52-year-old female, Mrs. Registry, presented with complaints of continuous pain in the abdomen for the past 4 months, vomiting on and off for 1 month, and yellowish discoloration of eyes and urine for 1 month, which is progressive and is not associated with waxing and waning. History of passage of clay-colored stools present. History of loss of weight and appetite. On examination, multiple scratch marks present over the abdomen and arms. It's a case of obstructive jaundice, probably due to carcinoma head of pancreas, sir.
When you said the summary, you should have included the gallbladder palpability. Did you include that in the summary? With a palpable gallbladder? Loss of on examination, multiple scratch marks present over. That's the only positive finding to be stressed? Or you need to say that the
Gallbladder is also palpable,
that
sir.
Then only we will be just
Yes, sir.
to us a diagnosis. So your diagnosis, come to the diagnosis.
It's a case of obstructive jaundice, probably
I
due
just
to.
want to stress one very important thing. Students, when they write the diagnosis, in our state especially, they are now having a tendency to write a paragraph. No. What is actually a provisional diagnosis? A provisional diagnosis is always with probability. And the provisional stands for probability. There is no need of adding unnecessary words. Probably, most probably. What you made as an arithmetical calculation out of a historical diagnosis and out of your inspection finding is the net sum as the provisional diagnosis. This may be right or wrong. On investigation, it may be entirely different. There is no need of adding probable, probability, most probably, etc. because it is provisional. Got my point?
Yes, sir.
Yes. So due to carcinoma head of pancreas.
Yes, sir.
So can you attribute all the points towards carcinoma head of pancreas in this patient? Just focusing towards carcinoma head of pancreas.
So the patient has a history of pain, then history of vomiting, which is
Your pain was in the epigastrium. Was there any relieving factor?
no, sir. It relieved by itself, sir.
In carcinoma head of pancreas, what's the nature of exacerbation and relieving factor? There may not be any
Food.
exacerbating factor.
Food intake.
Food
fatty
intake
food.
may exacerbate at least temporarily, but relieving factor, there is a described entity. What is the described entity of relieving factor? Did you ask that? Sitting forward, as in case of
Leaning
pancreatitis
forward,
pain.
Leaning forward.
Sitting forward, so that the tumor may fall gravitationally little at least, though it is encroaching. So that may relieve in some, but it's more evident in case of pancreatitis than carcinoma. So that, okay.
Then the patient has history of jaundice, sir. Progressive jaundice.
There was no waxing or waning, there was no jaundice-free interval,
Yes, sir.
and pain was progressive. So, if somebody argues with you, no, it is not carcinoma head of pancreas, it's only periambulary. What are the points in the history and the finding to contradict it? Finding almost same for both, isn't it? You may get a, but history,
Sir, painless intermittent jaundice
Ah.
is in periambulary, sir.
So here it is progressive with clay-colored retain and scratching tendency or itching tendency more, isn't it?
Yes, sir.
And the urine
Urine
High
is high colored.
remains so, isn't it? Okay, anything else? Shall we go to investigations? Yes. How will you investigate this patient? Management of the patient includes, for undergraduate sake, always when you say management, it includes investigation
and
as
treatment.
well as treatment, isn't it? And investigation for a very easy way is investigation to know the fitness of the patient, general system here, and investigation specifically to diagnose or to exclude our provisional diagnosis, to confirm or exclude our provisional diagnosis. That's the way you are supposed to say. Okay.
So I would like to do biochemical investigation first, sir. So LFT should be done. Alkaline phosphatase, AST, all the levels should be checked. Coagulation profile should be done, sir. And then serum albumin
It's
levels.
again one of my very favorite, topic for discussion. I would clinch on to the LFT first of all. For example, said also again with 90 to 95% accuracy. If you know how to interpret an LFT, you can type the jaundice. In an area where now MRI, CT, ultrasound even may not be able. So how will you type? What are the points in favor of obstructive jaundice and what is the reason for LFT alteration?
Sir, LFT total bilirubin will be raised.
Okay, agreed. Yes.
Conjugated-
More of conjugated
conjugated
than
bilirubin
that
will
also
be
agreed.
raised.
Come to the enzyme level because of time level. The enzyme
Alkaline
level. how will you-
phosphatase level elevated.
Oh, which one?
Alkaline phosphatase.
Okay. And what about OTPT? Alanine transferase.
Aspartate transferase and alanine transferase will be elevated.
That will be also elevated. For undergraduate sake, even that is not sufficient for my answer. How
Gamma
elevated?
glutamyl transferase will be-
How elevated and what is the reason? You should know.
Sir, it is secreted by biliary epithelium. So
Very good answer. That's what I want to know, whether you know it. So alkaline phosphatase is specifically increased because its source of production is from the lining epithelium of both intrahepatic as well as extrahepatic.
Extrahepatic.
That's why it should be very, very high in case of obstruction. But there is a back pressure to the hepatocyte cells. Intrahepatic canalicular drainage may be slightly impeded, but there is a back pressure affecting the hepatocytes. And per se, the hepatocytic enzymes may have a reflux, and that will account a mild to moderate rise. So in obstructive jaundice, what you get is typically a very high alkaline phosphatase associated with a mild to moderate OTPT level. What's the case of hepatitis? Hepatitis in the opposite. If you have a crisscross like this, on one end alkaline phosphatase is elevated, that is moderate. On the other end, OTPT is elevated, alkaline phosphatase is moderate. What is it due to?
sir, hepatic jaundice, both conjugated and unconjugated will be raised, sir.
That is about bilirubin. Leave alone bilirubin. Bilirubin is interpreted from physiology onwards. So we are not, we all know it, presumably. But about OTPT and alkaline phosphatase. Will you get in, as I mentioned, in aflatoxin poisoning or paracetamol poisoning? What is the one which is very high?
Aspartate transferase, sir.
What is that? Because it is from the
Liver.
is it specifically produced from the liver cells alone, or is it non-specific?
No, it is not only from the liver cells, sir.
Where else is being produced? There are other sources like lungs, like intestine, kidneys, to a tracer. So it's non-specific, but it's very high wherever there is an insult of the hepatocyte. So because then there is a inflamed hepatocytes totally, there is an impediment of the intrahepatic canalicular system, and that accounts a cholestatic phase. So you get a mild to moderate alkalinity. That should be the answer. Can you just name, because you have answered well, can you just name a specific hepatocytic enzyme? One or two?
Specific hepatocytic enzyme, sir. Aspartate transaminase.
No, that is not specific. We said both are non-specific.
Alan.
Anybody from the forum? Any?
Gamma glutamate transferase.
One at a time. Please stand up and answer, please, because there is no mic which I can supply. Very good answer. One more is there.
5 nucleotide.
5 dash
nucleotides.
So these are, because this is 5 dash is being done elsewhere in some big laboratories nowadays. GGTP is since long. It's also asked as done as a tumor marker. That is the reason why it is, because hepatocytic secondary deposits in the liver will be producing GGTP rise, and that is even done as a marker of breast carcinoma, other carcinomas, when you suspect secondary.
Okay, sir.
So far, so good. So, but in our time, there were other constituents like thymol turbidity, etc., which is not being done now. But the bilirubin interpretation also you should know. Whenever there is conjugated, you should think of either intrahepatic or extrahepatic cholestasis to obstructive jaundice. When you get OTPT very high rise, it is all actually either this. But then the bilirubin will also help us about the jaundice, whether it is due to excessive hemolysis, in which case you get a high load of
Unconjugated
unconjugated rather
bilirubin.
than the conjugated. That is why it is helpful. These are the basics to be stressed about. Now come to the other diagram.
Then coagulation profile should be done, sir.
Yeah.
PT, prothrombin time will be elevated. Then ultrasound abdomen.
Why this prothrombin time elevated in case of coagulation profile in obstructive jaundice?
Due to vitamin
Sir,
K
why-
deficiency.
Vitamin K.
Dependent clotting factors are 2, 7, 9, 10, sir.
Why
So
vitamin K is low?
because bile, it needs bile for
absorption.
absorption of vitamin K.
Good,
One.
good answer. Good answer.
Then ultrasound abdomen, MRCP, CT scan.
What's
Yeah.
the MRCP? What's the advantage of MRCP over other investigations?
So it's non-invasive, sir.
And it delineates even even anomalies of the biliary tract as well as the topography of the biliary tract, normal topography.
What is the contrast you use in MRCP?
So we don't use
No
contrast,
contrast.
sir. Bile is the contrast. Then CT scan.
What are the things you have to look for?
Ma'am, we'll see the extent of the disease, site of the tumor, any metastasis,
Vascular invasion.
Vascular
Vascular
invasion
invasion.
of which
superior mesenteric artery, portal vein.
superior mesenteric
We'll
vein?
see if the tumor is resectable or not
Okay.
by means of it.
Okay.
You mentioned ERCP and biopsy. Is there any other biopsy or cytology possible other than ERCP? ERCP is supposed to be little invasive, isn't it?
Yes, sir. Endoscopic
The EUS, endoscopic
ultrasound.
ultrasound. It will help us for not always biopsy, but cytology, specifically from the, under the ultrasound guidance, you can have the tumor involved area and specifically a target, which is named as target cytology or target biopsies.
Very small CA kind of pancreas can be detected by ERCP. ERCP, endoscopic ultrasound. Ultrasound.
If you are asked about ERCP,
Yes, sir.
this is, if I ask one more clarification, is it done widely on a diagnostic purpose or on a therapeutic purpose?
It's not only done for diagnosis, sir. Both for diagnosis and therapeutic it can be used. Mostly for
Here
therapeutic.
it is written, which is, I agree with you, because we anticipate a biopsy wherever possible.
Yes.
Otherwise, ERCP, or you see gallstone demonstrated and it is impacted there. There is a therapeutic sphincterotomy required.
Yes, sir.
So it's mostly therapeutic than diagnosed. That is the answer should be. And ERCP is asked as a short note answer should be. Basketing is possible. Cholecystoscopy is enabled much more through that retrograde phase, etc. in case of open surgery.
Sphincterotomy is done in which position? Which clock?
2 o'clock, ma'am.
11 o'clock.
11.
o'clock.
Why? Because the vessels are arranged longitudinally. What's the complication of sphincterotomy?
Perforation, ma'am. Sir, treatment before.
You know what is in short for your purpose, MBBS purpose. Sphincterotomy, which part of sphincter is being cut? The longitudinal or the circular? This is better described distally as a conglomerate total longitudinal and circular. So it is that site where we are releasing, mainly meant for circular fibers than longitudinal fibers.
Sir, treatment first nutritional workup of the patient should be done and the patient should be made fit. Then we'll proceed to surgery.
If PT-INR is raised, how will you correct it?
Ma'am, vitamin K injections can be given, ma'am. 10 mg for 3 days. 3 to 5 days can be given, ma'am. IM injections.
Deep intramuscular.
Yep.
If it is not responding to vitamin K injection, how will you treat?
Ma'am, fresh frozen plasma can be administered, ma'am.
What is the purpose?
Sir, if it's not corrected, then
No, your answer is only one. What is the purpose of giving fresh FFP? In case you give 3 days vitamin K, still not
sir,
improving.
liver cell is already failed. So,
Oh. Now you are going zigzag way, but you know the answer. Maybe difficult to say now. Fresh frozen plasma is the clotting factor.
yes, sir.
We want to give the clot. Before we give vitamin K to make up clotting factor, we
So that's what I meant, sir,
we
liver
substitute
cells.
by giving. Yes. Yes. Proceed.
So work up the patient and then nutritionally.
What will you work? You have to assess the operability of the patient. If patient is fit for that, and then what is your goal?
So if the patient is fit, then if the patient is resectable, then we'll go for Whipple's procedure, sir.
How will you know the resectability of the patient?
Sir, if it is confined only to the pancreas, then it's resectable. Or if there is no invasion to other.
Would you like to include a PET scan in addition to the investigations before? Can PET scan help much?
Sir, CCT is no, sir. PET scan.
CCT is more than
More
enough
than
as
enough,
far as
sir.
abdominal operability is concerned. What CCT helps for operability assessment?
Which protocol?
Pancreatic protocol.
Ah.
So yeah, pancreatic protocol, 3 phases we can do through, sir. Arterial phase, pancreatic phase, and portal venous phase, sir. 20 seconds, 40 seconds, and 70 seconds.
And that will all be giving us an idea whether there is the portal vein and the spermicentric junction and the beginning of portal vein area can be having a resectability without much erosion by the lymphatics, lymph nodes there. That is the main thing. If that is there, if distant nodes, as to say in stomach, R1, R2, R3, etc., distant stations are not much like even our secondary station, even you can resect through that. Suppose if you suspect the parietal wall invasion, then you should think of MRI also being as the priority. And after that, what will you do? What is Whipple surgery?
Sir, pancreaticoduodenectomy, triple anastomosis is done, sir.
What's your time allotted? How many minutes? I may be lengthening my schedule, but disturbing others I should not.
Sir, triple anastomosis is done, sir. Pancreaticojejunostomy.
What is triple anastomosis?
Sir, pancreaticojejunostomy, cholecystojejunostomy, and gastrojejunostomy, sir.
Whipple's like cholecyst. Whipple's.
Choledochojejunostomy. Hepaticojejunostomy.
What is the meaning of hepaticojejunostomy? Why is it called hepaticogenesis? You are anastomosing.
Because the hepatic duct.
It should be in relation to the common hepatic duct, not in relation to the liver at all. That is
sir.
the thing to me. So it's hepaticogenesis means it's a common hepatic duct which is anastomosed to the jejunosis.
Okay, sir.
That's a common mistake which we ask for undergraduate exam. They say it is anastomosed to the porta hepatis. So, no, it is not like that. Yes. Okay. So, how will you mobilize that pancreas and the duodenum? There is a term, at least name, at least you should know.
Cauterization of duodenum.
Very good, very good. What is cauterization?
Finger
Sir.
between
Correct. Duodenum.
duodenum and portal vein.
Cauterization is separating the duodenum from the lateral peritoneum.
I have no prediction capacity, but I hope probably these guys may come for surgery PG because they are not lagging. They are not lagging behind an average level. So that's why we are asking some more to touch the first year PG level someday. Yes.
Sir, lateral peritoneal wall is separated. The duodenum is separated from the lateral peritoneal wall, sir. That process is called cauterization.
So you will have that mobilization of.
Right colic flexure. First we bring the right.
You will just incise the paracolic fold. You may mobilize a bit of the upper part of the ascending column, but it can be left alone also after a little more. But the paraduodenal fold from behind is mobilized forward. And then you can go behind. It's a surgery from behind for the pancreas and for the duodenal cells. So,
Any tunnel of love?
yes.
What do you mean by tunnel of love?
Space between duodenum and portal vein.
Duodenum or
Superior mesenteric vein and gastroduodenal ligament. We put two fingers, ma'am. One is through the portal vein. Below the portal.
to know whether there is infiltration or involvement of the portal vein. What are the parts removed in Whipple surgery from the pancreas? Apart from the head, what are the other things?
Ma'am, distal pancreatic duct. Terminal pancreatic.
Head of the pancreas, unsnate process and the neck. So before ligating the artery, we have to ensure whether you are
Patency, distal patency should be checked, ma'am.
whether the portal vein is free from the pancreas.
Can you get a mass in carcinoma head of pancreas?
Mass, yes, sir.
Palpable?
Palpable.
Maybe.
Can't say no, that is the only answer. But because rarely people are there, but usually no. Because what is the feature of a pancreatic mass if at all in the epigastrium? How will you clinically do that? Clinically diagnose it, clinically delineate that? What is the nature, characteristic of a pancreatic mass if at all? It is almost like pseudopancreatitis.
Pseudopancreas.
But pseudopancreatitis is big in size usually. What is the feature of pseudopancreatitis when you want to delineate clinically from a carcinoma mass of the stomach?
Sir, Ryle's tube.
No.
Test. The epithelium we'll check for the epithelium, sir.
Did you get my question? There is a lump in the epigastrium. I will clarify. The lump is delineated as arising from the stomach and stomach related mass or colon and as arising from the retrogastric or retroperitoneal organs. What is the test which is for helping you? Palpatory finding.
Finding of the head of pancreas mass.
Retroperitoneal from intraperitoneal.
How to
Yeah, that is, ma'am was clarifying a little more. How will you distinguish a mass of epigastrium which belongs to intraperitoneal and which belongs to
The
retroperitoneal?
mobility, we check for the mobility.
Which mobility?
It moves with respiration.
These are the basics to be stressed to the guys listening. Movement with
Respiration.
respiration. But the mass movement with respiration and abdominal movement with respiration, movement of abdominal wall with respiration are entirely different. Abdominal movement of the wall with respiration is actually anterior posterior. Whereas a mass moving with respiration is craniocaudal node. That is the thing to be said. So if you get paraaortic node, you get retroperitoneal node, pseudopancreatic cyst, or even if at all a pancreatic mass when palpable, that will not move with respiration, whereas other masses will move with respiration. What about other masses? Aneurysm, thrombus, abdominal aortic aneurysm. This is also technically retroperitoneal, so it will not move with respiration.
Okay, sir.
What are the sequelae of Whipple's surgery?
Sir, post-op, the patient can have pancreatic fistula or other complications like hemorrhage, leak,
Why do
wound
you get
infection.
pancreatic fistula?
So, sorry, sir.
Why do you get pancreatic fistula? What is the reason?
Sir, this. Why do you get pancreatic?
In Whipple's, you are removing the entire pancreas or only subtotal? Or
Only subtotal, sir.
so the duct may be having anastomotic problem, and that is leading to. What's the main fluid loss in a pancreatic fistula? Acidic or
Amylase, serum, we'll check for serum amylase levels.
is it acidic or alkaline?
Alkaline.
Alkaline is loss. So you get relative
Alkaline.
acidic body
al-
pH. So
okay.
you may have to make it up by other means, correcting total metabolic disease. What is the antibiotic which is used in abdominal surgery prophylactically now? If you want to.
Cephalosporin, sir, third
Because they said
generation.
there is time, that's why I'm just going beyond that probably because they may get questions like that. If you're happy, we can continue. If you want to stop it, I can stop it. Okay. But then this is the because I asked that question. Yeah, and this has to be taught. There is something named as prophylactic antibiotic therapy. He said, can you do surgery, Whipple surgery with prophylactic antibiotic, or you prefer to give a 5 to 7 days course?
A 5 to 7 days course and then go for surgery.
No, because any surgery, if it's a clean or clean contaminated surgery, can be done on prophylactic. This is a clean contaminated technically, not contaminate always. So we can have prophylactic also thought of it. If you want to add only, what is the best antibiotic of the present day for abdominal surgery?
Cephalosporin, sir.
Which cephalosporin?
Third generation cephalosporin.
Can you name one? What is the first choice of this?
Ceftriaxone.
That are gone are all those days.
Cefixim.
The proponents of cephalosporin were voting mainly for cefazolin, but not very freely. Now the latest in update and those things is
Cefixim.
no.
Ceftriaxone.
Still Cephro. Concept of that soft tissue injury all being covered by Augmentin, etc. is now no longer valid. It is actually the cefuroxime which ortho people prefer because of the concern. That is being now used for almost all abdominal surgery. Even. Cefazolin is not very freely available. Cefazolin is the first. Then now they are opting for cefuroxime. Even in update it is like that. Yes, I think my classmate, I
Very good
specifically thank my
presentation.
classmate, Dr. Your teacher, HOD, sorry, your professor, Unitan, because he has given me strict compartmentalization, but such Salim, you can take time. So that's why I was just going to enjoyed just the session here also. Enjoyed the session here also as if in my own institution or elsewhere.
Yeah, did well, ba. Good. Congratulations. Yeah.